Hello and welcome back to another podcast of 1 Minute MRCP by Dr. Raza. Today we'll talk about the treatment of HIV. So if a question comes up, so we should know that antiretroviral therapy is started regardless of a CD4 count. If the patient is infected with hepatitis B, then antiretrovirals with anti-hepatitis B virus activity are preferred like emtricitabine, lamivudine, and tenofovir. In renal impairment, tenofovir is usually avoided. A few words about the drugs of HIV. So the rule of thumb is that nucleoside reverse transcriptase inhibitors, they end with "ine", protease inhibitors, they end with "vir", non-nucleoside reverse transcriptase inhibitors have "vir" in the middle like nevirapine and efavirenz. The treatment should be started as soon as possible regardless of CD4 count. Usually a combination of 3 drugs with 2 NRTIs with either a protease inhibitor or atripla is a common combination that contains efavirenz, tenofovir, and emtricitabine. NRTIs are zidovudine, lamivudine, stavudine, dedanosine, zalcitabine, and the common side effects of nucleoside reverse transcriptase inhibitors are peripheral neuropathy, mitochondrial toxicity that can lead to dilated cardiomyopathy. However, HIV cardiomyopathy is less common than it is due to the side effect of medicine. Zidovudine can cause anemia, myopathy, and black nails. Moreover, myalgia, myopathy, myositis can be detected with the help of elevated creatinine kinase, and a picture of rhabdomyolysis can come in the exam. Nausea, pancreatitis, lactic acidosis, and lipodystrophy are the common side effects of stavudine, didanosine, and zidovudine. Tenofovir causes liver damage, lactic acidosis, sudden worsening of hepatitis B is seen if the treatment is stopped. Non-nucleoside reverse transcriptase inhibitors include nevirapine, delavirdine, efavirenz, and atravirin. The common side effects of nevirapine are rashes, acute hepatitis, skin rash can be due to hypersensitivity, so a low-dose therapy is given for the first 2 weeks to observe for the rash. These side effects can include P450 enzyme interaction as well because nevirapine is an enzyme inducer. Efavirenz can cause neuropsychiatric syndrome. Protease inhibitor including indinavir, nalfinavir, ritonavir, and saquinavir have the side effects of hyperlipidemia, hypertriglyceridemia, P450 enzyme inhibition. So PIs are primarily inhibiting, whereas NRTIs are primarily inducing P450 enzyme, lipodystrophy, and specifically indinavir can cause renal stones. So the common causes of treatment failure in HIV are poor adherence, drug interactions or absorption problems, primary resistance or superinfection with a new resistant strain. So the test for resistance is usually done at the baseline. If the exam asks for the question, so the most appropriate course of action is to arrange an urgent resistance test if the patient is not responding to conventional antiretroviral therapy. If HIV is associated with tuberculosis, efavirenz with NRTIs have little effect on the plasma levels of rifampicin and it can be considered. Now a few words about the opportunistic infections, how they can be prevented and treated. So disseminated MAC infection is a common association with HIV. So we first treat MAC, then we start antiretroviral therapy after 2 weeks of treating MAC and monitor for IRIS, that is immune reconstitution inflammatory syndrome, that can occur in this scenario when antiretroviral therapy is started before the treatment of MAC. Cryptococcal and tuberculous meningitis, in that case ART is usually delayed for 4 to 6 weeks and amphotericin and flucytosine are to be given first. A few words about antimicrobial prophylaxis related to CD4 counts. If the counts drop below 250 cells per microliter, then coccidioidomycosis prophylaxis is given in high-risk area. It is fluconazole 400 milligrams per os daily. If the count falls below 200 cells, then PCP prophylaxis in the form of double-strength Septron is given. The counts less than 150 warrants treatment and prophylaxis for histoplasmosis, especially in the areas where there is high risk for exposure or who live in a hyperendemic area. Itraconazole 200 milligrams daily is usually given. Counts less than 100 cells increases the risk of penicilliosis, and the counts less than 50 cells increases the risk of MAC. Azithromycin 1200 milligrams orally once weekly is given for the treatment prophylaxis of MAC. So the landmarks for terminating primary prophylaxis are for MAC if the cell count is 100 cells or more than that for 3 months. For PCP and toxoplasmosis, we can stop prophylactic treatment if the cell count is more than 200 cells for 3 months. Cell count more than 150 for 6 months warrants stopping treatment for histoplasmosis, and so on for coccidioidomycosis and penicilliosis prophylaxis. Lipodystrophy is commonly associated with HIV and its treatment. There is an increased lip deposition that can lead to premature coronary artery disease. Hypertriglyceridemia can lead to insulin resistance. Moreover, antiretroviral therapy can cause insulin resistance syndrome. Hypertriglyceridemia can occur even in the absence of protease inhibitors, and that has to be kept in mind. The treatment for mild to moderate disease is dietary modification and exercise. Predominant hypercholesterolemia or a mixed picture warrants the use of statin, and for hypertriglyceridemia, fenofibrate is considered. Protease inhibitors interact with statins, so simvastatin is contraindicated and pravastatin is the drug of choice because the metabolism is not dependent on the CYP450 system. Cryptococcosis is a common A-defining illness. It's the most common fungal infection in the central nervous system and the most common fungal disease associated with HIV. Space-occupying lesion, meningitis, or meningoencephalitis occur with cryptococcosis that is characterized by gradual onset of fever and these symptoms over a period of 1 to 2 weeks. CD4 counts less than 100 cell increases the risk. India Inc. test is commonly asked and is diagnostic for cryptococcosis. Amphotericin B, flucytosine, is used for the treatment and lifetime suppression is done with fluconazole. Cryptococcus neoformans skin lesion can be detected with Gomori's methenamine silver stain that show budding yeasts. Fluconazole 400 mg per day followed by 200 mg per day for 8 weeks is usually given for the treatment of these skin lesions. HIV immunization. It's an important topic and commonly asked in the exam. Vaccines that can be used in all HIV infected adults are hepatitis A, B, H. influenzae B, influenza parenteral, Japanese encephalitis, meningococcus mense, meningococcus ACWY, pneumococcus PPV23, poliomyelitis that is parenteral, rabies, and tetanus diphtheria. The vaccines that are contraindicated in HIV infected adults are cholera, influenza intranasal, poliomyelitis that is oral, so parenteral polio can be given but oral polio should be avoided, and tuberculosis, BCG infection prevention vaccine should be avoided. So hepatitis B, pneumococcus and early influenza can be given. Polio vaccine is not recommended in HIV because it's a live vaccine, whereas parenteral polio vaccine is acceptable. MMR vaccine is usually contraindicated if the CD4 cell count is less than 200 cells only. H influenza B vaccine can be given at any CD4 count, and it is only recommended for splenic dysfunction, recurrent pulmonary infections, or previous infection with H influenzae, and there is an increased risk of recurrence. Shingles vaccine or varicella vaccine is usually safe and immunogenic. Caution is to be exercised in immunocompromised state, and it should not be used if the CD4 cell count is less than 200. Kaposi sarcoma is associated with HIV. It is caused by HHV8 virus. It is common in HIV and transplant patients with a CD4 count less than 500. It is transmitted usually through a sexual contact. The common manifestations are on the skin, GIT, and lungs. Purple papules or plaques on the skin or mucosa of the gastrointestinal or respiratory tract are common. It's most commonly occurring on the face. Respiratory involvement present with massive hemoptysis and pleural effusion. Chest X-ray shows pulmonary nodules. Lymphocytic inflammation and proliferation of endothelial cells, that are the spindle cells, are common histopathological findings. The treatment is primarily radiotherapy and resection. It becomes smaller as immune function improves with antiretroviral therapy. Chemotherapy with antiretroviral therapy is another option for the treatment of Kaposi sarcoma. There are certain other dermatological conditions related to HIV like eosinophilic folliculitis. There are three main variants of eosinophilic folliculitis, that is classic EF, immunosuppression related EF, and infancy associated EF. The most common is immunosuppression related. Clinical presentations vary slightly, but histopathologically the forms are identical. Classic EF, also known as Ophuge disease, is an eosinophilic pustular folliculitis, and it is more common in the Japanese population. HIV is also associated with abnormal vaginal bleeding due to cervical dyskaryosis, advanced HIV with HPV co-infection. So patients with HIV should have yearly smears as per BIVA guidelines. HIV positive females who are less than 26 years of age and men who have sex with men should be immunized. In Britain, immunization is offered to all females aged 12 to 13 years. AIDS retinitis is typically caused by cytomegalovirus, and it is one of the complications of HIV/AIDS occurring in the eye.